Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today's video is Blinkin Brainstem, and we'll be taking another step down our journal journey. Today's video is about the nociceptive blink reflex. Before we dive in, though, I want to do some community housekeeping and give a little bit of background information that's pertinent to know before we jump into the paper itself. The purpose of the Journal Journey series is to explore the current scientific literature around CRPS so that we, as people with CRPS and our loved ones, can have a better comprehension of the mechanisms and underpinnings that drive CRPS forward so that we can know what is happening inside of our bodies and make informed life choices based on that understanding. And also to reduce a lot of the fear and the isolation that comes from not knowing what is going on. I also want to be clear that while I do attempt to provide high quality content in line with current medical understanding and empirical evidence surrounding CRPS, I am a patient awareness advocate, not a licensed medical professional, and nothing on this channel should be taken as professional medical advice. I am one of the people who had a very hard time getting diagnosed. I spent years looking for answers, not knowing what was going on inside my body, not getting the help I needed from the medical system, and even now that I do have a diagnosis, I have a very hard time being taken seriously, finding doctors who know what CRPS is, and even those who do know really don't have a deep understanding. It's superficial at best, and I'm still, again, not taken seriously. So I'm doing what I can as someone who has to do this research anyway to improve my own quality of life, and since I'm already doing it for myself, I figured might as well disseminate this information outward to solve a problem that I think is very real and is not being appropriately addressed in the broader community. I do think the research is definitely improving in the scientific community, for sure. In the last multiple years, definitely a sharp uptick in the papers that are being produced on CRPS, for sure, but on a broader community level, I still see a major need that is not being addressed. So, as far as my goal with this channel, what do I want to do? My purpose here in the community is to increase the understanding of how CRPS operates so that people with CRPS can effectively, efficiently, and affordably reclaim their autonomy and their agency to improve their quality of life and have some hope that things can get better and that they can make it better, that they can have actionable steps to improve their quality of life and that it is not out of reach. So I want some community feedback. How is my channel doing in regards to that goal? With the content that I'm putting out, is it understandable? And my simplicity to complexity ratio, especially with this journal journey content where I'm breaking down some very complex papers, can you understand it? Am I breaking it down enough, or do I need to make it even more basic? Or is this a good level? Or do you want more detail? Is it too basic? What about the length of the videos? I've cut them down a lot, but do I need to cut them down more? Personally, I'd rather not. I'm autistic. I really don't like cutting out so much of that information. For me, that's just not good. But I understand that CRPS can cause a lot of focus and concentration issues, and I don't want to make them so long that people just can't get through the content. I needed the journal journey refresher for me because of my period of being unhoused. I lost a lot of the momentum that I had built up while I was housed, but I feel like I've made good progress on that. I'd like to start putting some more daily life content in there, like the Cold is Coming video or Noshing for Neural Health, where I was talking about tyrosine and tryptophan and how your food improves or detracts from the neurotransmitters that you're producing, things like you can do in your daily life as opposed to just breaking down other people's peer-reviewed articles. So what kind of ratio would you like to see for that? Because I still want to break down the articles as well, but what kind of content ratio would you like to see? Do you think I'm meeting my goal for this channel? If not, how would you like to see me improve or change my direction a little bit? What do you think I could do to better meet my stated goal for you? What would you like to see? Okay, with that addressed, please leave a comment or something. Let me know how I'm doing. Some information to know before we jump into this paper, because the paper is fairly complex. They don't really break down what the blink reflex is. They just jump into it assuming that you already know. The blink reflex protects the eye from foreign substances and it helps control visual focus. It has 2 stages, an early stage that is focused on one side of the face, one eye, and a late stage which does both eyes. When this reflex is functioning properly, it is fast and even on both eyes and protects your eyes from damage. When there is some sort of neural dysfunction or some sort of pathology, there is slow, delayed latency or some sort of uneven kind of blinking that can reveal that pathology. We are going to be focused on the late stage of this reflex, and this circuitry is in the brainstem, specifically in the trigeminal spinal nucleus and the facial nucleus, and we're going to specifically be focused on the trigeminal spinal nucleus today. Don't worry about where that is. I have pictures. In later slides, you'll be able to see it. Many factors can influence this blink response, and it can also modulate the strength of blink activity based on learned conditioning and nervous system dysregulation. Something else we need to discuss is habituation versus sensitization. And you could kind of think of this like a spectrum, with habituation on one end and sensitization on the other. Habituation is the ability to decrease your response after repeated exposure to a stimuli. And the opposite end of this spectrum is sensitization, which is a progressive amplification of a response to a stimuli. Okay, with that information, let's talk about this paper. Impaired pain processing at a brainstem level is involved in maladaptive neuroplasticity in patients with chronic complex regional pain syndrome by Thoma, Drammel, Goff, Lotz, Fleischmann, and Strauss from the Department of Neurology at University Medicine Greifswald in Germany. This was published on December 6, 2022, in International Journal of Molecular Sciences. Let's take from the abstract. Neuroinflammatory mechanisms and maladaptive neuroplasticity underlie the progression of CRPS, which is prototypical of central neuropathic pain conditions. While cortical maladaptive alterations are well described, little is known about the contribution of the brainstem to the pathophysiology. This study investigates the role of pain modulatory brainstem pathways in CRPS using the pain blink reflex, which not only provides a direct readout of brainstem excitability, which is the strength of a response to stimuli, and habituation, which is the ability to decrease a response after repeated exposure to painful stimuli, but also may be suitable as a diagnostic biomarker for CRPS. The R2 area, which we will discuss later, and its habituation were assessed following repeated above-the-eye electrical stimulation. Between group comparisons included evaluations of diagnostic characteristics as potential biomarker for the disease. Patients with CRPS showed a substantial decrease in habituation on the stimulated and non-stimulated side. This is the first study to reveal altered nociceptive blink reflex habituation as a pathophysiological mechanism and a potential diagnostic biomarker in CRPS. An introduction to complex regional pain syndrome. CRPS is a chronic pain condition that follows limb trauma in approximately 7% of cases and is accompanied by sensory motor dysfunction. Pathophysiological local inflammatory processes, peripheral pain sensitization, blood vessel motor dysfunction, and maladaptive neuroplasticity are thought to account for the majority of clinical features. Maladaptive neuroplasticity involves mechanisms of central sensitization, which is an inability to inhibit firing and an inability to tune out stimuli. Is thought to play a key mechanism in the progression of the disorder, involving disinhibition at different levels of the pain system, including spinal and trigeminal pain neurons and thalamocortical pain networks. Now, the thalamocortical area is where a lot of the sensory processing happens, especially visual processing. Changes promote alterations in different brain areas involved in sensory motor function, as well as emotional aspects of pain, which have been reported in both animal and human models. While cortical secondary maladaptive alterations in CRPS are well established, little is known about the contribution of brainstem circuitry to the pathophysiology. Brainstem pathways are assumed to be substantially involved in this pain modulation network. They are therefore critical to the initiation and/or maintenance of pain, and are thus predisposed to the development of chronic pain. Introduction to the pain blink reflex. Brainstem pathways can be assessed neurophysiologically using the nociceptive blink reflex. The nociceptive blink reflex consists of one early, same-sided, few-synapsed R1 component, which is the blue arrow on the lower right graph, and two late, both-sided, multi-synapsed R2 component at the brainstem, which is the pink arrows in both of these images. Understanding the role of habituation deficits, which is basically the ability to, over time, tune out repetitive stimuli at the brainstem, would improve the pathophysiological model of CRPS and help identify novel therapeutic targets through non-invasive brain stimulation and potential biomarkers for CRPS. Both aspects are of substantial clinical interest, since CRPS often has a poor prognosis despite treatment. Fast initiation of treatment is critical to limit disease progression and improve patients' quality of life. Early and correct diagnosis of CRPS is essential, but often difficult. The study aims and the author's hypotheses. The present study aims to fill the gap and examine several hypotheses, indicating an emphasized role of the brainstem in CRPS and its potential as a diagnostic biomarker through a more comprehensive assessment of the nociceptive blink reflex. The authors hypothesized that 1. Patients suffering from CRPS would show a substantial decrease in the nociceptive blink reflex as a potential diagnostic biomarker, indicating a damaged protective autonomic reflex for mechanisms of central sensitization. In more detail, the authors expected a decrease in habituation, which is a decreased ability to diminish response to a repeated stimuli over time, of the R2, which is the late component where both eyes blink, and an increase in the R2 area, which is the excitability or the strength of the electrical response, after repetitive stimulation. In short, they expected to see an increased sensitization to stimuli with reduced inhibition. In addition, the authors expected to see 2. Significant association of clinical parameters such as current pain levels, CRPS severity, and CRPS duration, and electrophysiological results such as habituation and the area of the R2 component. Participants and clinical characteristics. 13 patients with CRPS and 13 healthy controls recruited through support groups in northern Germany participated in this prospective case control study, investigating polysynaptic trigeminocervical R2 nociceptive blink reflex response. The participants were between 18 and 85 years old, and CRPS patients had unilateral chronic CRPS type 2 of the upper limb. The exclusion criteria were the affectation of other limbs, other neurological or psychiatric diagnoses other than CRPS, including primary headache syndromes, and other chronic pain syndromes. General demographic characteristics, including age and gender, were recorded for all participants. Presence of CRPS was rechecked according to the current diagnostic criteria. CRPS-specific characteristics, including the initial event, side of the affected limb, and disease duration, as well as comorbidities and actual medication, were assessed at the study inclusion. Pain levels at rest and during movement on the day of the examination were assessed, and the disease severity was classified using a CRPS severity score, and all of the CRPS participants showed severe symptoms. In this graph in the lower right, you can see the trigeminal nucleus with the bright pink arrow pointing to it in the brainstem, with the nerves running to the face. The results. There was a significant group effect in blink reflex habituation. Post-study analysis showed that the ability to adapt to repeated stimuli only at the short interval of 3 to 5 seconds showed a significant difference between CRPS patients and healthy controls. The testing also showed a trend for an increased R2 excitability area, which was where the pink arrows were, at all the interstimulus intervals, which means hypothesis 1 that they proposed was correct. For the area under R2, there was a group difference between patients with CRPS and the healthy controls, only on the stimulated side. So when they were doing their electrical stimulation, they weren't doing it on both sides of the face. They were only doing it on one side, which you can see on graph B to the right. However, there were no significant associations between the clinical characteristics and the electrophysiological parameters, which means hypothesis 2 that they had put forward was actually incorrect. Blink reflex and brainstem involvement in CRPS. Before this study, there had only been one study that used this method to investigate the excitability of the brainstem interneurons in patients with CRPS. That study found reduced R2 amplitudes, and R2 habituation was not investigated. The result of this study found that the deficit in habituation, which is the ability to tune out a stimulus over time, during stimulus repetition in their CRPS cohort was of high interest, since reduced habituation response of the blink reflex has been reported in patients with migraines and is thought generally to reflect impaired information processing between the brainstem, thalamus, and higher cortical areas. Impaired central information processing, altered excitability, and mechanisms of disinhibition at brainstem pain modulation circuits are thought to result in a pro-pain state, contributing to a reduced pain relief ability and an increased sensitivity to incoming somatosensory stimuli. The blink reflex can provide information on the peripheral nervous system and central nervous system functions, their excitation, and the transmission and modulation of pain information. The R2 component, which remember that was where the pink arrows were, especially when used in short interstimulus intervals, which was 3 to 5 seconds primarily, habituate after repetitive stimulation readily in healthy people, while those with persistent facial pain or migraine showed substantial reduction in habituation. So the results that these authors found fit with existing literature from other diseases involving brainstem pathways in pathophysiology, using the blink reflex as a potential biomarker for CRPS. Using a generalized linear model, revealed that the habituation, or the ability to diminish a response to stimuli over time, of the R2, which is that trigeminal nucleus at the brainstem where the pink arrows were, at an interstimulus interval of 3 to 5 seconds, and the R2 area, which reflects the excitability of the brainstem, at 8 to 10 seconds, had a potential to discriminate between CRPS patients and healthy group. These results generate the first evidence for the blink reflex to have a high sensitivity and specificity as a potential diagnostic biomarker. Since alterations of habituation have been reported in other pain diseases, it must be hypothesized here that they are not disease-specific, but rather indicate impaired sensory processing at a brainstem level in general. Based on this, the blink reflex may be considered a diagnostic biomarker for various pain conditions, pathophysiologically involving mechanisms of central sensitization. A perspective identifying a valid diagnostic and treatment biomarker will be increasingly important since there is evidence that long times between the onset and diagnosis and delayed insufficient therapy are predictive for CRPS chronification, which is associated with persistent, severe pain, impaired sensory motor function, and reduced quality of life. Now, what were the limitations in this study? First, the authors had a small sample size, which did not allow them to investigate alterations of the nociceptive blink reflex in the context of different phenotypes of CRPS. Secondly, they investigated only patients at the chronic stage of the disease, so future studies that investigate a variant of the blink reflex as a clinical biomarker should include patients in the acute and subacute stages to assess its role in disease chronification. They also did not control for patients' medications in this explorative study, so another limitation is that they could not exclude potential pharmacological effects on central disease activity. And finally, since sensory disturbance with aspects of hemilateral hyperalgesia predominantly appeared on the affected side and electrical stimuli were delivered above the pain threshold, it would be interesting to assess the impact of the stimulated side, pain threshold, and different forms of nociceptive stimulation, such as heat impulses or laser stimuli. In conclusion, this study provides the first evidence of altered nociceptive blink reflex habituation in chronic CRPS and verifies the findings of altered nociceptive blink reflex excitability, indicating impaired pain processing at a brainstem level in those patients. The results consider the polysynaptic R2 response of the nociceptive blink reflex to be a diagnostic biomarker for CRPS, Future studies should evaluate the blink reflex as a clinical biomarker to predict treatment, response, or disease progression of CRPS. To sum that all down in one very short summarizing sentence, CRPS patients revealed a delayed blink reflex with decreased ability to diminish a response to repeated stimuli over time, and an increased excitability to repetitive stimulation in the brainstem in the R2 area. Thank you very much for watching. Thank you very much to my patron W for Shep. Your support really means a lot. If you like what I'm doing here on this channel, please engage the algorithm in some way, like, comment, subscribe. Please give me your feedback from earlier in the video. Let me know what you like or what you'd like to see changed or anything regarding my goals for this channel and your thoughts on it. If you'd like to support the work I'm doing here, I have a PayPal or a Patreon. They're going to be linked in the description. If you would like to see the sources or the images used in this, or you would like to have access to the slides, those will also be linked in the description. If you would like to see access to my website, that will also be linked in the description. Thank you very much for sticking with me. I hope you learned something today, and I hope to see you next time.